So welcome everyone. My name is Tracy Comans and I'm the Director of the National Ageing Research Institute, or NARI. So NARI is an almost 50-year-old independent medical research institute dedicated to research around older people. And our vision is a world where older people are respected, included, and have the opportunity to age well. And certainly what we'll be presenting today is a fantastic e-DiVA research project that fulfills the mission and the vision of NARI. So before we kick off with those formal proceedings, I would like to acknowledge the Bidjigal people of the Dharawal Nation, who are the traditional custodians of the lands on which we gather today. We recognise that sovereignty was never ceded, and we pay our deepest respects to elders past and present. I'd also like to acknowledge the Wurundjeri people of the Kulin Nation on where our offices at NARI are located in Parkville, Melbourne. But I want to extend that acknowledgement to all Aboriginal and Torres Strait Islander people across Australia and recognise their enduring connection to land, to culture, to community and to country. And as we meet today, let's reflect that these places that we meet on have been places of teaching and learning for many, many thousands of years, and that we commit to walking together in a spirit of respect and understanding. A little bit of housekeeping for those people online. It is a webinar, so you won't be able to unmute yourselves and ask questions, but there is a Q&A function that will be monitored. So please pop up any questions in there, and particularly thinking about the panel that we have this afternoon. That will be greatly appreciated. So the objective of this e-DiVA launch and finalisation workshop today is to officially launch the e-DiVA, the Digital Support for Dementia Carers platform. We want to foster knowledge exchange, engage key stakeholders in discussions on digital interventions in dementia care. And so I will now begin by formally introducing our first speaker, who really, I think, for all of us, really needs no introduction. So Professor Henry Brodati is a researcher, clinician, policy advisor and advocate for people with dementia and their carers. He is Scientific Professor of Ageing and Mental Health at the University of New South Wales and co-director of the Centre for Healthy Brain Ageing, CHIBA. He has published extensively, and I'm sure we've all read his work and been influenced by that in our careers, and is a senior psychogeriatrician at the Prince of Wales Hospital. So welcome, Henry.
Thank you, Tracy. I am Henry Brodati, as you've heard, and I work here. My office is on the 3rd floor, and but pretty soon we're going to be moving across the road. You might have noticed there's a lot of building that's happening here, and so we'll be moving there. And from a nice office that I have now, I should have a very hot desk that will be accommodating me. I'd like to welcome you all warmly, and especially those who've travelled far from to come here. And I know some of you got up very early this morning to make your flights and be here, so that's very appreciated. I'd also like to welcome the attendees who are online. I can't see you, and I hope you can see me. This is a meeting that has been organised by the e-DiVA group from NARI, led by Tuan Nguyen, and NARI being directed by Tracy, as you just heard. And the other partner is the Centre for Healthy Brain Ageing, or CHIBA, based here at UNSW. So we celebrated our 12th anniversary last October. This is really important, what's happening here today, because it involves family carers. On Thursday mornings, I do a clinic. I'll tell you about 2 patients I saw today. So one of them is a man who's got mild cognitive impairment. It might be Alzheimer's. It might be that he was a rugby player and had multiple concussions. It might be because he drank a lot of alcohol in his early life. I don't know yet. So still investigating it. But his short-term memory, you know what it's all about, is 0. And his wife says, she keeps asking me the same question over and over. And I have to keep telling him each day what we're going to do. And then he asks what we're going to do. And it's frustrating for her. And so I told her about Dementia Australia. Kale, you'll be pleased to know that. I told her about forwardwithdementia.org, and which is what we developed.
Sorry. Give me a moment.
Can I talk, Daniel?
Go for it.
Go. Okay, all right. And also suggested some strategies for her. The other person was a man who's got quite pronounced dementia. He was a solicitor. He's now almost lost his language ability. He was, a very bright man. The problem, and he's mainly able to look after himself, but he needs a lot of support. And he's got a level 4 aged care package, which is, we have a number of aged care packages in Australia, and it's hard to get them. There's a long waiting list, and they provide so many hours of care depending which level you're at. And his wife is stressed because he gets aggressive. He can't express himself. It must be very frustrating for him. And he's obsessed with money. He makes sure he's got $150 in his wallet, but he transfers it to another wallet, and then to a drawer, and then to somewhere else. And then he thinks somebody's stolen it. And then he can get angry with her. And then he might even hit her. And he's done that twice. She started him on some medication, and it's only been once in the last 2 months. And she has all these escape routes worked out. She's got the key to a neighbor's place she can go to. She has everything by the front door. She can go with her phone and the keys and escape if he's trying to hurt her. She doesn't want to leave him. She doesn't want to put him in care. He wouldn't do well in care. It's quite a dilemma. And so carers face a huge burden. And this is what e-DiVA is about. And this is what research is about. This is why we all do research. I mean, we like to get the papers published and advance our careers. But if that's all we're doing, you do better off going to private practice or doing something else. You don't do it for the money. That's for sure. But we do the research to try and find the best ways to help carers. And we all do that together. And that's part of what e-DiVA is. And this is based on the WHO program, the iSupport. And then the whole world is moving towards digital mental health. We just did a digital prevention program for dementia. There are people who are doing digital mental health for depression, anxiety, and there's no way that the population can access the services they need if they want to see a psychiatrist or a psychologist. You want to make an appointment? You can wait a year to get an appointment with one of those. So this is a way, and the results are very good with this. And so e-DiVA has been really a major development in trying to improve the care of the life of carers and indirectly the life of people with dementia themselves in that way. And so what we're going to hear today is about e-DiVA, about what's happening around the world, about the program that has gone from Australia to Vietnam to Indonesia to New Zealand, the Maori population there. And it's great to see people from each of those different countries at this meeting. So I'd like to thank you all for coming and look forward to 2 days of deliberation. I think the most important thing is we're going to hear the results of e-DiVA, but what's the next step? What's the next step? How are we going to get this out there? It's like we did our prevention program. What's the next step? How do we get people to do the things that will do that? We need to implement and translate that into practice. Thank you.
Sorry about that.
Okay, so thank you for those opening words, Henry. And it's going to be, I'm very interested to see how we go with thinking about the next steps, particularly in our panel this afternoon. So I want to introduce our next speaker, Cale Stokes, who is going to present on reimagining care, so the promise of digital health for dementia carers. Cale is an Executive Director of Services Advocacy and Research at Dementia Australia. And her portfolios span all of Dementia Australia's client services, as well as a range of strategy and policy initiatives. She's passionate about quality service delivery that meets the needs of people impacted by dementia, as well as elevating the voice of people living with dementia, their families and carers through a wide range of consumer engagement activities. She's also involved in undertaking systemic advocacy, implementing strong communication strategies, and building community awareness through dementia-friendly communities and supporting international and national research. So prior to this work, Carl's completed an MPhil and PhD in history at the University of Cambridge in the United Kingdom, as well as working as an editorial assistant in Belgium and running her own grant writing consultancy. So I'd like you to warmly welcome Carl.
Thanks for having to come after Henry. So I have got a relatively small topic to talk to you about today, which is reimagining dementia care. I think probably all of you have your own views and experiences of what that means, but Tuan has asked me to put the conversations that we'll be having over the next couple of days in the context of the broader dementia environment. So hopefully that's what I can achieve in my time here. And I'm not going to spend very long on this because I think everybody here knows the statistics of the impact of dementia globally. We know that there's more than 55 million people living with dementia around the world, and that number is set to more than double by 2050. So without significant disease modifying treatments or other interventions. And we also know that there's a significant cost, and I'm not going to be focused so much on the economic cost, but more on the indirect costs, because often that economic cost that we get around it costing $1.3 trillion, I don't even know how many zeros that has at the end of it, that has a significant component of informal care costs associated with it, because for every one person that is living with dementia, they may, if they're fortunate, have an informal carer that can help to support them either in the community or in other forms of care, including residential aged care. And that may include a whole family unit. It may include neighbours and friends. And for everyone that is providing support to somebody living with dementia, that is time away from lives, plans, careers that perhaps they were embedded in and have to look at doing things differently. So I think that's a really important context in the conversations we're having about e-DiVA, because we know that family carers are often the ones that are stepping up and having a significant impact on their own health and well-being. Here in Australia, we know that there's about 433,000 people living with dementia in Australia currently. Trends are similar to the global statistics, which is that we'll see that number double in the next 25 or so years. And we know that there's about 29,000 people living with younger onset dementia. So that is a dementia that is diagnosed under the age of 65. And whilst there are key components of dementia that are similar for both people living with the disease, but also family carers right across the age spectrum, for someone living with younger onset dementia, there may be the additional impact of having to exit the workforce earlier than they had planned, having additional financial strains on what they're doing, and potentially also younger children that are impacted in a way that older people may not have to experience with their families or do with their grandchildren, for example. So the impact of dementia is significant, not only on people living with dementia, and I think probably an important frame for our conversations is not to step over the impact that dementia has on people living with dementia. We absolutely have that at the heart of everything that we do at Dementia Australia, but it is really important to note that for family carers, some of the stigma and negative impacts that people living with dementia experience are also the same for family carers. So we hear from family carers that people tend to disappear from their social circles. There tends to be a sense of social isolation here in Australia. And I'm sure in lots of other countries as well, there tends to be a sense of awkwardness that people don't know what to say or how to bring the topic of dementia up. And so they start to disengage from people that are impacted. So we hear often that people living with dementia experience stigma, loneliness, social isolation, but so do their families and carers. And so it is really important that carers are able to remain connected. And when we talk about caring, there's probably two components that I want to draw on today. One is supporting the person through the disease trajectory. So understanding how to support people living with the condition as their cognition changes, as their needs may escalate, as their mood or personality may change, and being able to understand how to best support people right throughout that process. And then there's the other part, which is what I would call the kind of system wrangling, because we know that moving through, whether it be healthcare, disability, aged care, is incredibly complicated. And that's not, you know, throwing in primary care and how that might or might not interface with those parts of the system, how a hospital stay might escalate care needs or make things more complicated. So we know that there's so many challenges with being able to navigate the system. And I've had quite a few conversations with my colleague DY over the last couple of days about the sense that in Australia, we are fortunate that we have lots of government-funded programs that support people living with dementia. But with that comes more complexity, because we have quite complicated healthcare systems that don't talk to each other in the way that we would hope. And so carers often really struggle with how to navigate that system. You know, in some countries, there just are no care systems to tap into. In our country, there are plenty of care systems to tap into, but it's not easy to do it. So trying to find ways of being able to pull all of that information together, understand which services might make a difference at the right time, can be really, really challenging. And I think that's why digital health is one of not the only, but one of the opportunities that we have, because we know that ultimately people like to have face-to-face conversations and receive services in their communities. But we also know that that's not possible everywhere. And particularly being able to access services in appropriate languages with cultural appropriateness is not something that we've really nailed here in Australia yet. So that's why it's really important that we do have a range of products and services, including digital health, that is able to ensure that communities right across this country and globally are able to access services and care in the way that they need to. And that means that we can see access to things that perhaps would not otherwise be available if it was based on place-based services, because, you know, they're not able to get out to every single local community. And it can also bridge some of those geographical and cultural divides and make them more appropriate. That is a process of thinking that Dementia Australia has been focused on for quite a number of years now. We have developed a range of immersive education tools using technology platforms, gaming platforms, virtual reality goggles that can help people understand what the experience of dementia might be like. And that's a really important part of enhancing the caring role, whether it be a formal or an informal carer, because it can help to shift people's understanding of what dementia might be like. And once you experience something like that, you don't unexperience it. So once you've had that shift of understanding why somebody might be interpreting their environment in a particular way, you basically can then start to build that into the way that you deliver care and support as part of your caring role, irrespective of whether that is a formal or an informal carer. So it's a really important part of starting to shift people's understanding, but also make that kind of education accessible to people that may not have been able to get to, one particular location. So we started our immersive education journey based at our office site in Parkville, where we had a big environment custom built with special lighting and a huge big projector on the wall, which was fantastic. But of course, people had to come to it to experience it. So being able to get technologies that can go out and be portable and be able to reach people where they need them is a really important part of being able to provide support. There are some challenges, though, that I think we all need to be aware of and perhaps be talking about as we focus on the next couple of days. And Henry's sort of touched on that already, that we really need to be able to think about what's next. How do we make this sustainable? How do we differentiate what e-DiVA does in the market? Because, particularly in Australia, we are fortunate that we do have multiple different products and platforms available. And the last thing we want to do with technologies like this is make it more confusing for people. We definitely don't want that. So I think it's really important that when we think about sustainability of tools like this, that we also think about how they can make the caring journey more seamless. And I can't believe I said the word journey because I really don't like it, but the caring trajectory more seamless and not make it more complicated and more difficult to navigate the system than it already is. So I think that's a really important part. It's also important, I think, that we look at from a scalability point of view, that we think about whether it is scalable everywhere or whether there are particular communities and cultures that respond particularly well to that type of technology, but perhaps that other communities need something a bit different. And are there opportunities to look at things like e-DiVA and modify them to make them more appropriate to different cultures and communities? I know that there's also quite a lot of concerns around privacy and trust and the ethical considerations of holding people's data. And I think that, as a community where we're kind of more across the idea that data is held somewhere up there in the cloud. But in terms of thinking about how to protect that data in the long term and provide the level of assurance and clarity to people that data is being used for the purposes that it needs to is a really important part as well. And I think, I'll finish with the point that I started with, which is that it's really important to see how it integrates into the broader healthcare environment and that we don't add more complexity when we're trying to solve that complexity. So I think that's really important. And Tuan and the team at e-DiVA and many of the other research that Dementia Australia is involved with is very strong on starting to look at how we incorporate the living experiences of people either living with dementia or families and carers into not just the testing of a new product, but also the design and development of it. And I think that that's a really important component in any piece of research, whether it be a bench study or a technology design or a psychosocial intervention. That we need to think about. And I've popped some questions on the slide there as well of things that we really need to think about when we start to design things in the first place. How does it translate? Will it link to and complement what else is out there? What is our point of difference in this? And how do we make sure that people are clear about what that point of difference is? Is it scalable? And if it is scalable, where could it be scalable? So I think those sorts of things are really important to consider in the future of e-DiVA. And I've just popped more questions on the slide there about things that we can consider over the next couple of days, because I think, as Henry's already mentioned, these sorts of technologies are incredibly important for a cohort of people that are doing it hard. They're dealing with really complex issues on a day-to-day basis. It comes at the cost of their own health and well-being often. So it is really important that we get this right and that we can make sure that the thousands or hundreds of thousands or even millions of carers around the world are able to get the kind of support that they need, that they're able to access information when they need it, and that it's in languages and a cultural frame that is specific to them. So look forward to the discussions over the next couple of days. Thank you.
Thank you, Kat. And certainly, I guess I feel that we're still at the early stages, really, with a lot of this technology. So we've seen the promise for a while. We're now starting and getting some of the results and getting some really interesting, I guess, products finished. And now it's that journey about, will they be used? Will they be will there be uptake? What's the implementation journey? And how can we improve what we're doing over time? So certainly there's still a lot more work to be done in that field. So our next keynote speaker is Dr. Katrin Seher, who'll be presenting virtually today, looking at an overview of the WHO iSupport and iSupport network, where some of this work was inspired by. So originally trained as a psychologist, Katrin's been working with people with dementia and their families for over 15 years. In her current role at the WHO, Katrin is responsible for the implementation of the Global Action Plan on the Public Health Response to Dementia 2017 to 25, and its monitoring framework, the Global Dementia Observatory. She led the development of WHO's Global Status Report on the Public Health Response to Dementia and the recently launched WHO position paper on optimising brain health across the life course. She's assisting member states in developing comprehensive national dementia plans and formulating country-level responses for dementia and other neurological disorders. So welcome, Katrin.
Thank you so much. I hope you can hear me well. Greetings from Switzerland. Thank you for the bio. What it failed to mention is that in my life before joining WHO, I actually was a very proud CHIVA member myself, and I used to work and live with Henry on the 3rd floor of AGSM. So I am really sad that I can't be there with you in person, but I know exactly where you are, and I'm missing the Australian coffee. Now, my task for the next few minutes is to give you, excuse me, an overview of WHO's iSupport initiative, how it started and where we've taken it so far. And it's really all, as you heard from Henry and Kaylee, in support of carers worldwide who provide the tremendously important support for people living with dementia. Now, at WHO, our work is mandated and guided by the Global Action Plan for Dementia. It has a very bold vision of a world in which dementia can be ultimately prevented. But for those who live with dementia and their carers, they live well, receive the care and support that they need, with the more short-term to mid-term goal of really improving the lives of people with dementia, their carers, and families. The action plan has also, is arranged across 7 strategic areas for which global targets were defined. The global targets are for 2025, so this year is critical. And as you see on this flow chart here, we're not reaching our targets globally, and no country globally is reaching the targets. We've assessed the situation in the Global Status Report in 2021, and also submitted a formal report to governing bodies earlier this year, so that member states can decide actually next week, hopefully, about a potential extension of the Global Action Plan, because there is a lot more we need to do. For the strategic area of carer support, the action plan defined a global target of 75% of our member states to provide training and support for carers. And this is where iSupport and e-DiVA really fits in. Now, in the Global Status Report, we also highlight, or we took stock of where member states are and where the biggest gaps are. So if in the area of carer support, we found that globally, or among the countries that were surveyed and participated in our Global Dementia Observatory, access to carer support remains limited. Most of the support is provided in high-income countries. But when you look at low and middle income countries, you find that access to those services in rural and remote areas is only provided by 17% of the countries. So you see that people who may not live in major cities would struggle to receive any kind of support. And I think this is also a topic that everyone in Australia would could relate to when we think of rural and remote areas. One point that the status report highlighted was also that carers need to be directed and guided to the available support systems and encouraged to use them, which is something that I remember from my clinical days, that it's hard. How do we convince a carer who's pressed for time and struggling with juggling multiple jobs and responsibilities to also take time for themselves and engage in training? And this is where GPs, or more globally, primary care physicians or practitioners, community health workers can play a crucial role in kind of prescribing or promoting accessing carer services and supports. And this is really where iSupport came in. The idea was born. It was developed with a large group or in an international collaboration across many countries, Canada, UK, China, also Australia, and in close collaboration with our collaborating centers. Now, what is iSupport? It was originally designed as a self-help or skills training. It aims to provide all the knowledge that a non-professional, a family member, would need in order to provide better care and support for a person living with dementia. And at the same time, try to prevent or at least decrease any of the negative mental, physical health problems that might arise from caregiving. With another goal of also improving the quality of life for the carer as well as for the person living with dementia. iSupport is based or grounded in WHO's MH-GAP guidelines, which are treatment and management guidelines for core mental and neurological disorders, and dementia is one of them. And iSupport is also then deeply grounded in principles of cognitive behavioral therapy. So it includes aspects like psychoeducation, relaxation, cognitive reframing, behavioral analysis, behavioral activation, and problem solving. iSupport itself consists of 5 modules that you see here on this slide, with 23 lessons in total. So it has an introduction to what is dementia, what are different types of dementia. It has one module on what does it mean being a carer, what does it mean caring for myself, not forgetting to care for myself. And then the 2 biggest modules on how to provide everyday care, and the last one on how to deal with behavior changes that often do occur. Didactically, every lesson consists of an overview to introduce the topic, and then presents a range of examples and interactive exercises so that the main content kind of is conveyed, and then has a check point at the end to see whether the carer understood the lesson. Excuse me. We originally started developing iSupport as a digital intervention to overcome exactly some of the access issues that we've heard about. But we learned very quickly that we will also need a hard copy manual. So iSupport is available as an online training in 2 generic versions, and I'll come to adaptations in a bit. We have a hard copy manual. We also have iSupport Lite, which extracts the key messages from the modules in a one-page summary or poster. We have a short video, and also all key messages of iSupport have been extracted and can be into a message library of dementia support, and could be sent via text messages to users. We have different cover sheets for cultural adaptations. But I want to give you also a bit of sense of where is iSupport currently used. So in its generic versions in Spanish and English, we host it on an online platform. We have more than 22,000 people worldwide registered for the course, and over 8,000 have successfully completed the entire module, so all the 23 lessons. And of those who completed, about 3/4 feel that the course content is strongly relevant for building the skills that they need, or for professional growth. Why do I mention professional growth? Because in PAHO, in the region of the Americas, where they use the generic Spanish version primarily, we found that iSupport was actually used by professionals. So these could be nurses, these could be psychologists, but because there is a general lack of training in dementia available, they kind of found iSupport being a really good introduction. We also survey our iSupport users of the English generic version, and we ask them, for instance, whether they feel that doing iSupport improved any of the following symptoms. And they could select none or multiple, but what you see here on this slide is that the vast majority of people say it makes them more confident in providing care, and it also improves the relationship between the carer and the person living with dementia. And also then has some effects on reducing stress, anxiety, and depression. But we also ask them about what they like and don't like about iSupport. So usually they appreciate that there is a lot of information and they have access to different sources of information. And they appreciate that they can do this in their own time and at their own pace whenever they do have some spare time. But we also need to acknowledge that it is a huge time commitment still, and to complete the entire iSupport content, users feel this is a barrier. If you're doing it virtually, you rely on good internet connectivity. And our WHO platform is admittedly not the most user-friendly yet. So people also do come forward and say, well, it is rather complex to navigate. But let me share some of the really exciting news or developments of iSupport over the year. And this is really our international network, and where the e-DiVA team comes into play. So we have, for the last, I don't know, 3-4 years, established this iSupport network. We have monthly meetings with network members from over 40 countries. At the moment, our iSupport adaptations or translations are ongoing or have been done in 37 languages and 57 countries globally. Network members like the e-DiVA team, they run randomized controlled trials on their adaptation. They combine iSupport with local support groups that local Alzheimer associations run. So there is a lot of knowledge sharing and inspiration going on in among this network. So I think we also feel that this is an important component of strengthening capacity worldwide in taking an intervention, a developed intervention, and then adapting it, changing it to the needs of the local community and making it work for them. So we're using the iSupport network also to obtain or to discuss what challenges they're facing. And I've tried to group it into these 4 buckets for you. On the program, we've already touched upon a few of them. So iSupport in itself is very long and time consuming, and in its current form requires a lot of reading, which doesn't make it necessarily very inclusive. The relaxation exercises that are included in iSupport, if you have to read them trying to relax, good luck with feeling relaxed afterwards. So that kind of then necessitates having audio tapes, for instance, for those components. In some countries, and I remember that was the case also for Australia, there was feedback from carers who field tested it and saying that there are topics missing. I don't have all the answers that I need in iSupport, and that is right. And the problems with bandwidth I've already mentioned. Then there is one group of challenges all faced with the adaptation process. And how do I go about actually translating the content, not just by pure linguistically translation, but how do I make it relevant for my local community? So that is a long process and also sometimes very costly. And the network tries to support its members there. The third bucket concerns research and evaluation of the program. So is the intervention working or having the intended effect once it is being implemented? And the challenges that network members would share is that recruiting for clinical trials is very difficult, and often we're facing very high attrition rates. At the time of COVID-19, which is when the iSupport network roughly was formed, COVID restrictions didn't make recruitment any easier. And then we're also trying to shed a light on what the best methodology might be to evaluate the effectiveness and the usefulness of online tools by, basically exchanging notes between the different teams. And then the last bucket, which I think for us at WHO is one of the biggest challenges, is really the implementation and the uptake. So maintaining a carer program long term is a big investment. And some of the low and middle income countries definitely don't have the funds. And even in high income countries, what we often see is that the development is funded through a research grant, but then what happens after the grant runs out? And the other point I've alluded to already earlier is how can we increase the uptake of iSupport? So, or any carer support actually is how to support carers in looking after themselves, basically. And on my last slide, I want to actually leave you with some of the inspirations and the ideas that we really gain from our international network, because I think, yeah, this is really an inspiration also for me in my everyday work at WHO. Is how can we improve this? How can we make this this better? Learning from all the ideas that different groups bring to the table. So we now have different audio files for iSupport, and it ranges from just providing audio files for the relaxation components to the entire program being read or available as an audio book of sorts. There are teams that look at particular algorithms for tailoring the content of iSupport so that it's easier for the carer to get to the lessons that they need. We have teams that use user interaction and a Q&A. And also, excuse me, teams that added or supplemented iSupport with new content and their own content. Where for to make the adaptation easier overall, we're trying to streamline the processes and have countries help themselves in translating content, or we've also connecting interested people to network members who have already done certain translations. And we're currently, with the support of the iSupport network, also updating our adaptation guide. So hopefully later this year, there will be an easier step-by-step guide published by WHO. How can we enhance research collaboration? One longer-term goal is certainly that we have standardized research protocols for all the different iSupport adaptations so that we can ultimately pool data and make use of the diversity and large variety of information that we're collecting from around the world. But for now, the different team members are just supporting themselves in designing protocols and discussing what outcomes they might be using and so on. And how can we improve funding or sustainability for iSupport adaptations? This remains one of our biggest tasks or questions also at WHO, exploring what sustainable funding models might be. We usually advise civil society organizations that approach us to implement iSupport in their country to work as closely as possible with government, because if it's tied, if iSupport and carer support is tied to a government program, there are better chances of it being long-term sustained. And when it comes to scalability and using iSupport in different settings, where this is work in progress, and we're really drawing again on our network members and the different ideas that they come up with. And with that, I think it's a perfect segue back to, or yeah, in terms of setting the context, to go back to e-DiVA, where e-DiVA comes from. So learning also about the results of e-DiVA and the plans for the future is super exciting for me personally, but will also be extremely helpful for the network members and all the countries that will come after and trying to tackle a similar problem. And with that, I think I'm finished. Thank you so much for your attention, and good luck and congratulations on completing the e-DiVA.
In mental health, dementia care and ageing. The research focuses on culturally adapted psychosocial interventions, carer support, digital health intervention and cross-cultural dementia care. She has extensive clinical training from hospital-based settings and worked across academic research and health institutions in India and Australia. And of course, we have Dr. Tuan Nguyen, the leader of the project and a principal research fellow at NARI and professor at Swinburne University of Technology, and also an adjunct associate research professor at the University of South Australia. So his current research lies on the development and implementation of national dementia strategies with a focus on low and middle income countries, culturally tailored interventions to improve the lives of people with dementia and their carers, and medicines that can induce or worsen cognitive impairment and dementia. His expertise covers broad areas, including pharmaceutical policy, pharmacoepidemiology and drug safety, healthcare management, public health and behavioural sciences. Associate Professor Nguyen is the founder and leader of a large dementia research collaborative in the Asia-Pacific region and the principal investigator on 3 international grants. He's authored over 70 publications, 47 conference presentations, and has attracted nearly 10 million in research funding, and perhaps a little more now.
Yes.
I think, yes. So welcome both Upasana and Tuan to deliver the findings of the project.
Thank you, Tracy, and I welcome you all again to the official launch of the e-DiVA program. I'm Upasana, and I had the privilege of being the project manager of this exciting initiative at NARI. And today I'm delighted to walk you through the journey of e-DiVA, which brought together digital innovation, culturally responsive design, and a commitment to support carers of people with dementia. Now, before I dive into the project itself, I would like to take a moment to acknowledge the institutions, organizations, and many individuals who made this work possible. This project was funded by NHMRC eAsia Joint Research Grant. Our funders were NHMRC, the Ministry of Science and Technology Vietnam, the Ministry of Research and Technology of the Republic of Indonesia, the Health Research Council New Zealand. And we had various prominent institutions involved in the project. We had also our industry partners who were involved in the project, and a special thanks to our technical partners, without whom the project would not have been possible. So thanks to Ecomedia and Fire Films. And This project is a collective effort built on the expertise, insights, and commitment of an incredible team, led by our executive committee, who spearheaded the project, our international advisory board group. We then have our animation production advisory committee, who have been amazing and spearheaded the development of 51 animations in English, Bahasa, and Vietnamese. I would also like to thank our e-DiVA national teams, the Australian team led by Associate Professor Tuan Nguyen, the Vietnamese team led by Professor Tan Pham and co-led by Bin Nguyen and Professor Trung Nguyen. I'm sorry if I have mispronounced your names in any ways, but yeah, you were amazing. And the New Zealand team led by Associate Professor Sarah Callum, and the Indonesian team led by Professor Yuda Turana. And you see, instead of the clip arts, I do have a picture of our team when we met in our annual meeting in 2023. And a special thanks to the carers and professionals who helped in the co-design process and tested the platform with us. So with the gratitude in place, I will now talk about what motivated e-DiVA, or what motivated the project, what challenges were we trying to work on or solve. And thanks to Kale and Katrine, who set the stage for me wonderfully. So I think I'll just skip through the slides because I don't need to add anything to what they have already said. But what I would add is that LMIC, the lower middle income countries, are the epicenter of the dementia issues that we are facing. And along with that, even in high income countries like Australia and New Zealand, the care for dementia is often fragmented. And especially the CAL families, or the culturally and linguistically diverse families, face greater burdens. So like it has already been mentioned, dementia carers experience stress, anxiety, significant burden, and they are vulnerable, though they're so essential, but they are vulnerable. And that's where e-DiVA comes in. Because traditional support models though effective, they are resource intensive and sometimes unsustainable. So online and app-based intervention offer a solution to that. We harness that and try to work on digital programs, digital platform, and develop something which should be scalable and accessible. And WHO's iSupport provided us a strong foundation for that. So we did not have to start from scratch. So the project was basically not only to adapt the WHO iSupport, but to reimagine it as an interactive, scalable, and more accessible program. I'll not go into what is iSupport because Katrine has already done the job so wonderfully. Our project was built on 4 core aims. It was to co-design and culturally adapt iSupport, virtual assistant. Like I mentioned, we are reimagining iSupport. So we wanted to have a virtual assistant feature to it. So it was to co-design and culturally adapt it for 4 countries from the Asia Pacific region: Australia, New Zealand, Indonesia, and Vietnam. Second aim was to test the feasibility and preliminary effectiveness through a pilot RCT. The third aim was to build capacity for the digital intervention development. And the final aim was to disseminate the findings and promote networking and collaboration. To address these aims, we divided the project into 4 main work packages, which was, again, to co-design, the feasibility and pilot testing, the capacity building work package, and dissemination. Now, today's program is one of the key part of the dissemination project, that work package that you see there, listed there. I'll start with what we thought was needed to develop an intervention like e-DiVA, which was capacity building of our international partners, researchers who were involved in the project. This was done through various training workshops, including the Theory of Change workshop, which provided us a roadmap for the project. And also, of course, understanding dementia, how to develop a digital health intervention, and on cultural adaptations. Now, co-design was integral to the project. It was the approach that we adopted, and the co-design process was involved in almost all the main stages. So translation of iSupport program into local languages to ensure cultural relevance. Now, the English version was already adapted for Australia, so we used that program, but we did adapt it for those Vietnamese and Indonesian communities. New Zealand adapted it for their cultural context, so did Indonesia and Vietnam. Then we also did more formative research to ensure that the adaptation was actually relevant. After the adaptation, it was the e-DiVA website was developed based on carer feedback, and it was a iterative process again. And finally, once it was developed, the member checking of the program was done. Now, the cultural adaptation altogether from the 4 countries, we had around 72 participants. The main adaptations was basically simplifying the language, providing more culturally relevant examples, and focusing on visual enhancement, especially including videos, voiceovers, animations, and having more culturally relevant examples. After the adaptation was done, we needed to use the adapted content to develop animated videos. Now, this was a very interesting process, and a lot of you here in the audience today were involved in the process. I mentioned the APAC, the Animation Production Advisory Committee, and they were integral to the process again. So there were a lot of various rounds of reviewing and feedbacks, and finally, out of the scenarios available in iSupport, 51 animations were developed. They were then their voiceovers done for Indonesian, Bahasa Indonesia, and Vietnamese. Once we had this animated videos ready, and this was actually going on at the same time. So the iSupport virtual assistant platform was also being developed. So the platform has multiple language support in English, Vietnamese, and Bahasa. New Zealand, of course, used the English version. And each of the countries had their own respective languages. There were text and voice search options, personalized learning modules, because we also had a carer needs assessment that was integrated into the platform, service directories, and a diary function. I said that very easily, but this whole process took a long time. I have a very daunting task. I have been given 10 minutes to talk about 4 years of very intense hard work. But anyways, we do have, finally, we had these features that I mentioned, and Tuan will take you through it. The Vietnam team, and again, hats off to them, they developed 76 videos with real life actors. So they did not take the animations because that was what more culturally accepted there. So they had real life videos that were developed. Of course, the website is in a continuous process of improvement, and we use user insights to keep on improving it. So these are the versions that are available currently and have been tested or are being tested. After the platform was developed, we went to the user testing phase of the virtual assistant. So we had around 56 carers and professionals from all the 4 countries who tested the site and gave us their feedback. So the major feedback was developing guiding videos. So though the features were available, they asked us to develop short videos guiding them about how to use each feature. So that was something that was incorporated. There were suggestions for improved navigation, layout, and the need for better onboarding and peer support options. So this was something that we tried to integrate before we started the RCT. So now let me talk about the randomized control trial. So it was a pilot study, but it was quite an interesting one, and it was a multi-site randomized control trial. In the Australia side, we had 60 people, 60 participants randomized. We had with 36 from New Zealand, 20 from Indonesia, and Vietnam. The recruitment is still ongoing, but we have 36 participants recruited till date, 37 participants recruited till date. If you see, I've already also put a plus 24, plus 16. So this 40 carers from Australia and New Zealand did not really meet the cutoff for their perceived stress scores, but they did fulfill all the other criteria. And they were interested in using the program. So they were also randomized into the site, but we did put them in a subgroup. The RCT design was simple. It was, they were either randomized to an intervention where they received the e-DiVA program immediately for 6 months, or they were randomized to a waitlist control group in which they received the intervention after 3 months. So they all the participants received the intervention, but at varying points. The preliminary findings, so I'll not go into details about the data analysis because we are still doing a lot of the analysis and it's ongoing. However, the feasibility outcomes are very encouraging. We have good recruitment, randomization, and retention feasibility. And the user satisfaction with the content is strong. However, intervention engagement remains a challenge. And we'll be talking about it in our future discussions and especially focusing it on it tomorrow. We also took carer feedback especially on the platform acceptability. So you used exit interviews. The participants were participants from the RCT. So in Australia, we have around 27 exit interviews done and the data collection is still ongoing. New Zealand has completed 29 and Indonesia has done like exit interviews for all the participants who were in the RCT. Now, there are several emerging themes, especially on usefulness and relevance of e-DiVA. It was found to be beneficial, especially by the newer carers. Experienced carers, they requested more advanced content. They thought that what was there in there was very relevant, but this was something they had already learned from experience. So they needed something which was more specific, say about mobility issues, aggressive behaviors. The learning preferences were mixed. Some people preferred detailed modules, the iSupport course, while others preferred the shorter videos. The need for emotional and social support was apparent, and the interest in the peer support function, getting links to external networks were very high. There were, of course, a lot of barriers. Time constraint, as we all know, in all dementia care intervention program is one of the biggest barriers. There was emotional exhaustion and also limited digital literacy, especially for the older carers. The recommendations were mostly about more advanced content, high video quality, faster performance of the website, improved navigation, expanded language options. So there was request for more language options than the available ones. Finally, a few key insights from all the phases of the project is that there has been high cultural acceptability due to localized content and language-specific modules. The website was found to be valuable for newer carers. Experienced carers wanted advanced content, like I mentioned. The flexible, self-paced learning with videos was well received. There were some areas for improvement, of course, like navigation, font size, loading speed. Digital literacy barriers were noted, as I mentioned, especially among older carers, interest in peer support and external service connections. And finally, engagement was, though it was there, but was limited by time and emotional fatigue. Finally, let me come to the last work package, which was the dissemination of the project findings and networking. So we are trying to disseminate the results of the project through national and international workshops to share what happened in the project, what were the outcomes. We have done various presentations nationally and internationally. Publications have been done. However, a lot of it is currently in works, in development. And this finalization workshop and the launch at Sydney is one of the milestones in the dissemination process. So that's where I will leave you all at. Now I'd like to hand it over to Tuan to take you through the site and officially launch the program. Thank you all.
Good afternoon, everybody. First of all, I would like to start by acknowledging the traditional custodians of the land on which we meet and pay my respect to their elder past, present, and emerging. And I also would like to extend that respect to all Aboriginal and Torres Strait Islander peoples who are joining us today. Pasana already thanks all the partners, all the carers, all the participants, the researchers, and the funder. And I don't want to repeat that, but I really would like to express our gratitude to the e-DiVA teams, both in Nauri and Shiba UNSW, for making this conference, this meeting possible. So thank you very much. Now you have listened to the keynote speech by Kelly and Katrin talking about the importance of the support for carers of people with dementia and the roles of technologies and what the iSupport network is. We also have listened to Pasana talking about the e-DiVA components, the e-DiVA process, and now I just need to make the official announcement to launch the e-DiVA virtual assistant. And I will show you what the virtual assistant look like.
More than 90% of people living with dementia in the community are supported by unpaid family carers. Most of those carers have had no formal education in dementia care. Caring for a person with dementia at home can at times be quite stressful, impacting on carers' mental and physical health, which may result in a loss of productivity and income, especially for carers still working.
The e-DiVA website has been adapted from the World Health Organization iSupport program. This provides online skills, training and support for families and other informal carers of people living with dementia to improve their mental health and well-being. e-DiVA aims to empower dementia carers by providing help through tailored content based on their caring needs. Accessing relevant information is easy because the website allows you to search for specific topics, recommends content specifically for you, and provides a list of services available in your local area.
The e-DiVA website helps dementia carers access and use key functions such as the iSupport online course, organized into modules and lessons, videos showing situations carers might face and possible ways to deal with them, diary, where you can manage your events and appointments, peer support, where you can connect with other users, support services available in your area, chatbot, a tool designed to provide real-time support. There's also a voice or keyword search function to help you find the materials you need. e-DiVA project, empowering dementia carers with an iSupport virtual assistant.
So that is the Thank you very much. That is the e-DiVA look like, and I really would like to just demonstrate how convenient, how easy it is for a carers to look for a specific solution for their real problems in real time. Because if you remember in the keynote by Katrin, she said that the iSupport online program, one of the limitation is time consuming, right? And carers, they don't have time to a lot of reading, and they don't have time to sit down to study lesson by lesson, page by page. So we just make it simpler, user-friendly, and very convenient for the carers who are very busy and overwhelmed with their caring duties. So for example, if I am a carer and I face some problem with aggression, for example, then I can just go into the website I either type aggression, then it's come with the link to the video clip or the lesson that I can go into study. If I don't want to type, and I just click on the microphone and say it out loud, then it will also refer me. For example, my person with dementia have some hallucination. For example, I just click on this one and say hallucination. Then it's come up with the link, and here is the examples of the video showing step by step the solution for hallucination. And I just give you a look at that.
Hi, I'm Christina, and this is my sister Maria. We both care for our father.
Antonio, who has dementia.
A few weeks ago, I came home to find Papa really upset and staring at the carpet. Hi, Papa.
No,
What's the matter?
there's a deep hole there.
Where?
There.
Oh, Papa, it's just a rug. Come on, let's have something to eat and I'll find a new rug to put there instead. Which seemed to work for a few days.
Until I came home to find Papa upset again, except for a different reason. Hi, Papa.
Who are you?
Papa, it's me, Maria. What's wrong?
Maria, who are those people?
Papa, there's nobody there.
Who are you talking there?
Papa, you're imagining it.
No, I'm not. I can see them.
When Maria told me, we decided to ask his doctor, in case there was something else wrong that was causing Papa to see things.
Antonio, I understand that you've been having some problems, so I've reviewed your medications, but there's nothing there to suggest they might be causing you concern. Your daughters have explained to me what's concerning you, and I suggest looking at the e-DiVA website to learn more about how to deal with this.
Yes, we're familiar with that website.
Thank you, Doctor.
So we looked up the e-DiVA site,
Which advise that you don't argue with the person, but instead you offer them reassurance.
and even distract or redirect them, which can also help calm them down.
So we thought we'd try that next time.
Who are you?
Papa, are the people troubling you again?
I can hear them talking.
It might be the people next door you can hear.
You think?
Also, it's so dark and shadowy here. There we go. Has that helped, Papa?
Maybe.
Besides, Papa, you're not wearing your glasses. Why don't we go and find them? Here they are.
Papa, play us a tune.
What you like, mia bella? Tarantella.
Tarantella Napolitana. Papa still thinks he hears or sees things from time to time.
But at least we can support him and make sure he doesn't get too upset.
For more information, including further advice on possible ways to deal with a situation like this, and for other sources of assistance, please refer to the e-DiVA online course.
That is an example. It's very simple, right? Very simple and very convenient for carers who are overwhelmed with their caring role. And once again, I would like to thank Jane and Ron, the committee members, for the development of the virtual assistant. And thank you all for your great contributions. And by that note, I would like to officially launch the e-DiVA virtual assistant, and we will finish the section now, and we will have the afternoon tea. Over to you, Tracy.
Thank you. Thank you so much, Tuan, and so exciting to see, that in action and what people have access to on the e-DiVA website. So I encourage you all to go and have a look. And yes, we're going to break for afternoon tea. We'll be back 3:15 sharp with our panel. For those of you online, and for those of you in the room, we have some afternoon tea outside. So if we make our way out, and we'll come in a few minutes before then. And I know in that role and as a co-investigator, this project is very instrumental in the success and driving and supporting the team in that process. She has a background in medical anthropology and public health, and her research focuses on cultural diversity, dementia, and mental health. She's led numerous studies on dementia prevention, awareness, diagnosis, and care, particularly within culturally diverse communities in Australia and internationally. She's a very successful researcher, having authored over 150 publications and produced more than 70 multilingual films, comics, and animation. And it's certainly changed, I think, the way that we think about delivering some of these interventions and communication with culturally and linguistically diverse communities. So in recognition of her contributions, she was inducted into the State Government of Victoria's Multicultural Honour Roll in 2022. So I'm going to hand over to Juan and Bianca for this session.
Thank you very much, Tracy. This one? Okay. Thank you, Tracy, for the kind introductions, and good afternoon, everyone. And welcome to today's panel, Co-Designing e-DiVA, the Digital Health Innovations in Dementia Care for Real-World Impact. The aim of the panels is to discuss e-DiVA as a model for inclusive, practical, and scalable digital intervention. And today's conversation brings together dementia family carers, healthcare professionals, policymakers and advocates, and researchers, each playing a vital role in shaping the futures of dementia care. I'm one of your chairs today. As Tracy's already introduced, my name is Tuấn Nguyen from National Aging Research Institute and Swinburne University of Technologies. And I'm joined by my co-chair, Professor Bianca Brisnas from La Trobe University. So at the heart of our panels is e-DiVA, the Electronics Dementia Inclusive Virtual Assistant, a co-designed tool being developed to support family carers, particularly in communities where access to resources may be limited and culturally mismatched. Our focus today is not only on technologies, but on how lived experience, practical care realities, and research evidence can come together to design digital solutions that actually work in people's daily lives. We will explore what e-DiVA is and how it was developed, what carers and service providers truly need, and how digital tools can align with policy and service systems to create lasting impact. And we already watched the videos, so we already know what e-DiVA is. And now I'm delighted to introduce our diverse panels. Ms. D.Y. Suhararia from Alzheimer Indonesia International, bringing a global perspective on digital equities and innovation. Dr. Kelly Stokes from Dementia Australia, a leader in consumer-driven advocacy and policy shaping. Family carers with lived experience navigating the system and digital tools, Dr. Jane Thompson and Ms. Simone Ventura. Community aged care provider sharing insight from service deliveries and discussing how to integrate digital tools in their existing services. Mrs. Thuy Nguyen from Australian Vietnamese Women Association in Melbourne. And Mrs. Anita Bonanno from CoAsIt in Sydney. And digital health researchers working on the co-design and evaluations of e-DiVA, including Professor Prem Jayaranman from Swinburne University of Technologies. As well as our co-chair, Professor Bianca Brisnas, and myself. So
To begin with, I would like to ask each of our panelists to share a short perspective on digital health and dementia care from their vantage points. First, we will hear from Ms. D.Y. Suarya. D.Y. is Regional Director of Asia Pacific Alzheimer Disease International. She's also the founders of Alzheimer Indonesia, an NGO that aims to improve quality of life of people with dementia and family caregivers, and works toward greater dementia awareness, care, and risk reduction in Indonesia. D.Y. holds a Master of Public Health from Curtin University in Australia, a Bachelor's of Arts in Journalism, Ohio State University in US, and a Diploma in English Literature from the University of Indonesia. D.Y. has more than 20 years of experience in public health, public-private partnership, and communication. In the past, D.Y. has worked as a health communication consultant with the World Bank, WHO, UNICEF. D.Y. has taken the lead in supporting 20 ADI members in the Asia Pacific in advocacy, leadership, and capacity building initiative. D.Y.'s mother was diagnosed with dementia in 2009 and has been her source of inspirations in improving quality of life of people with dementia, caregivers, and intergeneration through the establishment of the Alzheimer Indonesia since 2013. Her mother passed away in April 2017, but her legacy continues. D.Y. was the Value 20 Task Force leaders in 2022, and she has been recognized as one of the Aging Asia Global Aging Influencer 2021, and as one of the WHO UN Decades Healthy Aging 50 leaders to transform the world to be a better place to grow others. Over to you, D.Y.
Thank you for this opportunity. Thank you so much for this opportunity. What Tuan said about my mom, actually this is one of the reason why we're all here in supporting people with dementia and family carers, because I was one of them 15, 20 years ago, before my mom was diagnosed with dementia. Not knowing where to go, information is difficult. So I'm talking, I have two hats. One as my own experience as a carer for my mom for 10 years. But I'm also happy that because of the experience that lessons that she taught me, it led me to establishing Alzheimer Indonesia in 2013, and in helping 20 other countries in Asia Pacific under my role in Alzheimer Disease International. So from the global policy context, as we heard earlier from Catherine and Kale as well, how dementia created an impact to families, and how digital health and dementia care and support is crucial. And why do digital health digital inclusion matters globally? It is absolutely not the miracle solution for everything. And for dementia, as we also know, human interaction remains a priority. But in terms of information, as what Tuan also presented and Upasana earlier, the intention is to provide the key to these answers or solutions or guidance. So digital inclusion is the effort in ensuring everyone can have access, can use it, can benefit it from a digital technology. And we know there is all these generations, from silent generation to baby boomers to Generation X to millennials to Gen Y, Gen Z. I'm from the Generation X, and I'm even I'm not as savvy as my nephew and nieces. So, so sometimes they kind of usually tease me. why am I not a cool auntie, you know, for them, you know, not knowing how to navigate the digital space. But I think at the end of the day, how the digital space and digital health and dementia care provides the social connection, provides the knowledge, provides the access to informations and services. So it needs to promote equality, addresses inequalities, it needs to empower people, and it's also providing the whole information to know that you're not alone. So Alzheimer Disease International is a federation of more than 100 associations around the world. We have members in 105 countries. Australia is one of them. I'm happy to be here with my member as well. And Indonesia, my partner in crime, e-DiVA, as well here. So we play a role on this and how to connect the dots, because we aim to improve quality life of people with dementia and carers. We can't do it alone. We have to strengthen the members' ability and capacity, and technology is one way to connect the dots, and it link up to the WHO iSupport program that basically under the Action Area 5 on providing support for carers. So, so basically it's something that's important, it's needed, I think we have to take it to the next level on how to really use it, how to really identify all the support ecosystem that can really empower family carers in providing support for people with dementia and carers. That's from my take. Thank you. Back to you, Tuan.
Thank you very much, DY, for your global perspective. And now I would like to ask our second panelist, Dr. Kelly Stokes. Kelly is the Executive Director, Services, Advocacy and Research at Dementia Australia. Okay, so everybody knows Kelly. So the question to Kelly is, how do carer voice shape innovation and influence policies? And could you share some of the examples from Dementia Australia initiative to demonstrate your perspective?
Thank you. I feel like I should just pass the microphone across to Jane to answer this question, really, because in terms of how do carers influence projects like this, it's by being directly involved in them from the earliest stages of the project and reviewing the kind of progress as we go to make sure that what is being developed is relevant and appropriate and meets the needs of family carers. And in fact, Jane was telling me earlier that, you know, some of the content was reviewed and changed slightly on the basis of feedback from family carers because it needed to address particular challenges that that weren't already encompassed. So I think that's a really important part, and having an ecosystem in which those conversations are possible, making sure that there are multiple opportunities is really important. And I think something that globally, but certainly here in Australia, has changed pretty significantly over the last 10 or so years, and I've been around long enough that I've seen some of the changes, where we do see now research being co-designed with families, with people living with dementia in a way that 10 years ago did not happen. And I think that's a really important change and something that will continue. Well, it kind of has to continue now, doesn't it, Jane? Because we're, you know, that's the point of research, is to make a difference. And a lot of the work that Dementia Australia has been reflecting on in recent years is about how to make research practicable and able to make real world difference. And I think, you know, that's some of the things that we'll tease out a bit later in our conversations, because developing research in isolation from real world problems might be very interesting. And in fact, you know, I did a master's and PhD in history. I wouldn't say that it necessarily has real world implications today, but it was certainly fascinating to undertake. And it helped me think about problem solving in a particular way, but didn't necessarily reflect real world changes. So I think when we're designing and thinking about research, we really need to think about what's next from the outset to think about how we're going to make it sustainable beyond the life of that particular project. And a key way of doing that is to make sure that we're always building the voices of people that are impacted, that are going to be using the tools, incorporated into that the whole way through. And I think probably an indication of how Dementia Australia has approached it is that not only have we developed a broad network of people living with dementia and families and carers that we engage with in our systemic advocacy, in the work that we do, in the services that we design, to ensure that we have as wide a perspective as we possibly can. But we also developed an engagement framework called ALICE, which is about being authentic, drawing on living experience, being inclusive, collaborative, and empowering. And we've just recently developed our new strategic plan for the next few years and have actually had pretty much unanimous agreement by staff and our board and all of the people that we engage with that we should develop those principles as our values for the organisation. So I think it's a really important reflection of how seriously we take the inclusion of people with a living experience of dementia in every aspect of what we do. And I think that, from a research point of view, it's really important that we continue to do that too.
Thank you so much, Kelly. So I would like to move on with Jane. Jane is an experienced advocate for public involvement in all types and stages of dementia research and is an experienced contributor to dementia research. She has been actively involved in dementia research at the project, programs, and organizational level since 2010. Her experience as a carer of her husband, who died of Alzheimer's disease in 2007, inspired this involvement and commitment to improve the experience of others impacted by dementia. She was a founding member of the former Alzheimer Australia Consumer Dementia Research Network and involved as a public contributor to the former NHMRC Cognitive Decline Partnership Center and the former Dementia Collaborative Research Center. She was a member of Dementia Australia Research Foundation Scientific Panels, a member of the NHMRC National Institute for Dementia Research Advisory Board. She is currently involved in a number of dementia research projects, including one international project and programs of research for several Australian organizations and as a chair or members. So she was actively involved in development of the e-DiVA project, and now I would like to pass to Jane. Over to you, Jane.
Oh, well, this is my retirement activity. So, look, I'd just like to endorse what we've already heard, and that is that being a dementia carer is really, really hard, and that's not to be underestimated. The impacts vary, of course, depending on the type of dementia that the person is experiencing. It depends very much on the relationship that you have with that person. So spousal carers are going to be impacted very differently from perhaps someone who may be caring for a parent. The impacts on young people caring for a parent with dementia, of course, will be very different. So there's not going to be a one-size-fits-all solution to this. But, I think e-DiVA is a good start to providing some probably, general guidance for the most common experiences that you might encounter. But it was interesting, I noticed in your evaluations that people who were more experienced carers were actually wanting something a bit deeper. And I think this is one of the things that I found as a carer, that it was, not only was it really hard to navigate the system, it was very hard to find information that actually reflected what my experience was. And most of it was rather glossy. There were lots of sort of recommendations, and I'm going back to, this is 2004 when my husband was diagnosed. We've still got a lot of the same issues and we haven't solved them all yet. But a lot of what I was reading was you know, enjoy the rest of the time that you have together. There'd be a lovely picture of a couple walking hand in hand along the beach and, you know, and do the best you can. Whereas that was not what my experience was like at all. And eventually I did find some things that really resonated. So I think we probably need to sort of keep that in mind in developing any of the sorts of materials that we're going to provide to help and support carers. And if they're not there, then perhaps direct people to where they can find something which resonates with them. What else was I going to say? I think that's probably all, but I think just to reflect what I felt it was like when I became a carer, I always say that I felt like I was catapulted into a foreign territory where I had no roadmap and I didn't know the language. And that's what I think a lot of carers feel. And so access to information support is so critical, so vital, and not just through digital innovations, but of course that sort of one-on-one and also the support groups, say Dementia Australia's support groups, for instance. I had a very, very supportive support group for younger women caring for a partner with dementia, which I don't think I would have survived without that. So thank you.
Thank you very much, James. And once again, on behalf of the e-DiVA teams, we would like to express our gratitude for your great contribution to the development of the virtual assistant. And now I would like to ask Simons Ventura. Simons is the primary carer for her mother, who was diagnosed with dementia in 2018, and she is based here in Sydney and participated in the e-DiVA randomized control trial. So, Simons, once again, thank you very much for contributing to the randomized control trial and for being here with us today. You have successfully completed the e-DiVA randomized control trial, and you have indicated that you would like to continue to use it. And could you please share with us your experience using the e-DiVA? And could you also tell us how e-DiVA can help you in your caring role?
Jane, I think you've wrapped up in terms of a carer and information available. So I'll speak in terms of e-DiVA and how it's helped me. My background is not medical. I'm a human resources consultant, change management. Due to a autoimmune health disease, I sort of chose to put my career on hold and also to look after my elderly mum, who's 93, diagnosed with dementia, but wanting to have her independence and live at home. So I have my family and her family sort of trying to manage two households the best way I possibly can. Now, prior to e-DiVA, I researched, I Googled, I co-pilot, asking for some sort of support. I did call all the different organisations, which were helpful, but in order to get information, it's not timely, it's not on the spot. And the changes in my mother went from being forgetful, that was okay, to now hallucinating, getting angry, getting aggressive, and so forth. So e-DiVA for me was good in a practical sense. I went through all the modules, I went through the videos. It gave me just a sense of, you know, confidence that I was doing the right thing, because it's difficult. You just don't know sometimes how to react. But the saddest thing is the relationship that changes between mother and daughter. My mother was independent, intelligent. Now she's no longer that person. So in terms of the examples and the skills, it's great. It provides a little bit of a pathway, but the most difficult thing is accepting that this person no longer is the person that they used to be. And she's on level 4 home care, and I'm very fortunate that there is an Italian organisation, CoAsIt, who have got very caring people that come and sit with mum and provide a little bit of assistance. But in terms of the behaviours, the changes, the the practical side of things, e-DiVA really is a great tool, and I hope that it does go out there to people that care for people like Mum, and also individual carers. That's my experience, and thank you, Zara, for being there. We've laughed, we've cried. I've pulled my hair out, and also Professor.
Thank you very much, Moons, for sharing with us your experience of using the e-DiVA, and also I'm very glad to hear that you found e-DiVA useful for you. The findings from our e-DiVA user testing study and the randomized control trial show that actually the aged care providers play a critical role in improving the engagements of carers, family carers in using the intervention, in e-DiVA intervention. And actually, the aged care staff, they wish to have their companion version for them to improve the quality of care in their daily services. So today we have two panelists who are representative of our excellent ethno-specific aged care providers, Mrs. Thủy Nguyen, Aged and Disability Services Manager from Australian Vietnamese Women Association, and Mrs. Anita Bonanno, Head of Community Services, CoAsIt. I have same question for you both. What are the frontline barriers and enablers for integrating the e-DiVA into your existing service? Perhaps we go with Thủy first, then Anita.
Thank you, Tuấn. Thank you for the opportunity for me to contribute to this important discussion. And at IVWA, at the Australian Vietnamese Women Association, we are now serving 1,200 the elderly client from CAO backgrounds, which is from Vietnamese background, mostly from Vietnamese background. And as a community provider, we work alongside family carer like every day. So many of them caring for the loved one who living with dementia. So the statistic from our client is we have nearly 25% from our client who suffer from dementia. From our frontline perspective, digital innovation like e-DiVA is not only a timely, but it's essential. We know that family carers are often isolated, emotionally stressed, and navigating system that can be difficult to assess. Many of them are from CAO background where stigma, language barrier, and lack of tailored support further complicate their journey. And this is where e-DiVA shows real promise. It's accessible, culturally adapted, and flexible. Those qualities that match reality of caregiving at home. The integration of voice and text searching and the video-based learning resonates strongly with the carer who may struggle with written material or with formal education. And from the workforce perspective, look like e-DiVA can help extend our support beyond the business hour and giving carer a companion that they can turn to anytime. But we also see the barriers to adoption on the ground. Many older carers still have limited digital literacy, and they may own a smartphone, but they don't know how to download an app or how to adjust the setting. So, and when a carer is really exhausted, even a helpful tool can feel like one more thing to manage. It feels like exhausting for them. So what needed in our view, integration must come with a wrap-around support, like onboarding sections, community champions, or ongoing digital coaching. We also see an opportunity to embed e-DiVA into care planning conversation where the support worker or the care manager can introduce the tool in a relational way, not just at a link to click. Finally, as an aged care sector prepare for major reform like support at home, e-DiVA could play a key role in building carer capability, offering trusted information and emotional support in a scalable and sustainable way. In summary, the future of dementia care must be both human and digital. e-DiVA gives us a strong foundation. Now the challenge is to ensure no carer is left behind the process of innovation. Thank you.
Thank you. So I'm from CoAsIt, the Italian Association of Assistants. So whilst we did originally set up as an Italian migration service 60 years ago, Italian migration stopped in the 80s. So we've evolved our business to now provide aged care community services to multicultural communities across Australia. Me personally, I have only ever worked with called communities for over 20 years of my career. So I've been in aged care for 20 years, including residential aged care, independent living, and recently completed a master's in ageing at Melbourne University. So what we see as barriers and issues with, we've heard tremendously about carer stress today. It keeps coming up. Most of our complaints that we have as an organisation are around carer stress, the expectations of stressed carers versus the bureaucracy of an aged care package. They're very, very bureaucratic. We heard from Professor Henry this there are 4 levels, but those who aren't familiar with the system, the highest level of home care will get you 1.5 hours a day only. If you are, you're supposed to be able to stay at home as an alternative to residential. That leaves 22.5 hours for unpaid carer to have to manage. And dementia doesn't sleep. The night clocks are all over the place. So for me, e-DiVA is such a great bridging tool between that gap. As previously mentioned, it can support with all the bureaucracy. A lot of our arguments are around what we can and can't do. We heard the example of the gentleman who was starting to get violent, but he started to take a tablet, but we as service providers can't administer that tablet. It's a chemical, we need to do a chemical restraint form. Guardianship, I'll sign this form or cat for that. I get the complaint against me because I'm not a supportive service provider. Educational tools like, why don't you go look at that module? Why don't you understand what's causing that behaviour? Fix, instead of locking a door, behaviour support plan in place. Like that example, something so simple like it's a rug to us, but if the colouring, the shading's a bit off, remove the rug. Oh, but that rug's been there forever. Okay, but if we remove the rug, we might not need that psycho can't administer. So that's the really where it that frustration between service provider and then our rapport will improve. Why don't you have a read about what that medication you're giving mum really is? Because if you really understand that medication, you might want to invest the time in having a better behaviour support plan. Of course, there are circumstances absolutely necessary, but let's try those first. Let's quickly find, go in the chat group, someone within that app might have another option that they've done with their loved one. Something so simple. I've had a client whose father kept walking out the front door. So instead of locking it, they went to Bunnings, put a female toilet door sign, put it behind the door. Don't walk through the girls' toilets. You never walk through that door again. To chemical restraint and an environmental restrictive. So that's where we yes, we know about the but there's also a health literacy issue within cold communities. The doctor speaks this clinical jargon and then they go home and go, I actually don't know what that means. The biggest example is with diabetes. Oh, I'll have another piece of cake. I'll take a second tabletta. No, it doesn't work that way. So having what is your diagnosis? look like will also help. Carers are changing. We have a client who's 105, a client. Her daughter's 84, a client. Her granddaughter is 59, and carer who has to work. I'm in Sydney, guys. $10 in this city. So poor girl's juggling work, 3 generations above her that she is the main carer for. So everything's email, everything's a text, everything's after hours. So this app is perfect for those working professionals who are a full-time carer because with longevity, there are multiple generations in care, and with financial crisis around the world, more and more people are staying in work for a lot longer than they would have been before. So that's definitely a key tool, I think, for future generations. And as people do get a little bit more tech savvy, I mean, I can't see myself retiring ever. So I'll be one of those ones who's at work going, oh, let me just check that app. I'm really excited. You know, Tuan knows my wish list. I love that digital calendar. Wouldn't it be fantastic, Simone, if you could put all your appointments in the one calendar? They come to me, then I don't have to ring you 5 times. Hang on, when did you say the... Or we can put our care plan into that calendar for you. So every day you can go, oh, worker's coming at this time, then I've got that appointment, then we've got that checkup, rather than having one on your Outlook, one on this app, one stuck on your fridge. You know, Mr. Technology, make that happen, yeah? So that seamless integration, you know, API service and stuff, we can talk how we can have a one-stop shop for carers with busy schedules to have everything in one place. I think that's me done. Thank you.
Thank you very much, Thuy and Anita, for your insights. And now I would like to move to our digital health researchers. We have Prem, our lovely members of the advisory group, and Bianca, members of our executive committees. So the question for you, we have already watched the e-DiVA virtual assistant, the introduction videos, right? And now the audience already knows what the virtual assistant is. But many people are curious about how it was developed. And Bianca, can you share the insights of how e-DiVA was co-designed?
I hope what's evident already from what everybody else has said is the absolute need for researchers to be humble and listen to carers and providers, because we learn a lot more from them than I think they learn from us. And co-design, that is the fundamental premise of co-design, to have that humbleness and to take the rigor of a turn it on its head. That paper and some fancy actually going to meet people. We started with the e-DiVA. It's a piece of... It's not science. It's science fiction. And we said all of these modules, and we'll just... And of course, complete chaos and absolute rubbish. And we were completely down the wrong track. So, you know, I think many people of our consumers and providers rightfully call, what is this? Really, for goodness sake. And that's the polite version. And so we really had to recalibrate. And that's the point of co-design. And it's meant to be. It's chaos. Providing a service is chaos. You know, create a resource that reflects that reality. So we had to bring in a neuropsychologist who was from a cold background. We had to engage our consumers and our carers and our people with lived experience more meaningfully and more deeply. We had to recognize that just because we all had PhDs, as my auntie says, you're all FUDs. So it's not a very complimentary thing, that, you know, just because you're a FUD doesn't mean that you actually have any technical nous or creative now. So we had to actually engage a script writer and a proper filmmaker who knew what they were doing and not, cobbling it together like we thought we were. And get that insight and that grounding to bring in. So a project like e-DiVA, you can see it's almost like building a pyramid of Egypt, right? So you have this idea in your head, and you write it in the ground. You're going to build this great sort of pyramid, and then you actually come to building it and you realize all your foundations are rubbish. Start all over again. And then you do, and then eventually what emerges from that is something that is enduring and lasting and resonating with people. So I've probably given you a very the lame person's version of the co-design, but I think we'll stick to that language rather than talking to you about ideation and problem framing and prototyping, because, that's, again, back to the science fiction.
Thank you very much, Bianca, for sharing the co-design process. It is really painful because before we thought that, the iSupport contents was already culturally adapted. So very simple, just use the adapted content and give it to the animator, the professional filmmaker, and make it the video. But that is a really painful lesson for us, and it took us more than 2 years to revise and fix the problem. And now I would like to ask our tech members of the Project Advisory Committee, Prem, could you please share with us your insight on the importance of proper design in developing a digital tool like e-DiVA?
Thank you. First, I'd like to thank and congratulate the entire e-DiVA team. I think what you have done is sort of an excellent work. I know it was very hard to present 10 minutes. That's 4 years of hard work. So well done to the entire team. I made a lot of notes, and if I kind of respond to that, it's going to be, before I answer that question there, but I think I'll start with where you left. Technology is the perfect example of chaos theory. So you never know how it works, but it works, right? And so if you take individual parts, you heard everyone say that it's complex. Calendar system, the tech for calendar system has existed for 50 years. We still can't get it right. So I think the co-design process, right, for the purpose that it's built for, that's the critical aspect. I will just throw light pre-COVID. Most of you would not even gone for a hybrid. I remember doing a PhD literally on a hybrid with my supervisor because, research computer science, you sit in a room and do your own work. You don't speak to people outside. And that was Skype. And I don't know how many people actually use Skype. This is about 10, 15 years back. So the technology for this has existed for 30 years. But COVID came in and we all became desperate because we all are connected human beings. Unfortunately, in Victoria, we were not allowed to connect for years to connect. So we reverted to technology. And so I think the purpose was sort of, was driven by why we wanted to achieve that. And so coming back, I think one of the things, I think, DiVA, you mentioned, technology is never the solution. It's the means to what we want to address. And the key part, I used the word multidiscipline. And thanks to some of my colleagues, people like Penny, who really, and I think Sunil here also, I think you mentioned about researchers dropping off their egos or whatever. I think that's a very critical part in co-design, because often when we go into a room, we try to prove who the experts are. And technically, the panel is not the experts. We're actually part of the team here to learn more, right? So I think dropping that part of you to hear what the end customer wants. And so with e-DiVA, I'm so happy to see, because there's sort of consumer advocacy. There's literally every user of the system has been thought about. And congratulations to the team, because I would really say not many people halfway with the project will sort of scrap things and start again, because you always want to say you've done a great project and successful outcomes. But so it is tough, right? And it's not easy at all. And probably that's often why you're right. Proposals are science fiction. When you put it into operation, it never works, because that's how we write, right? And I think a bigger part is policy. And I think there's also our grant systems. Unfortunately, I think the last decade or so, a lot of these grant systems do not emphasize on having the right people involved in winning a particular grant, which means that you are continuously being funded to do some work, and you put co-design because it's a nice term to use, but you just co-design among yourself, and that's not co-design, right? So how do you actually enable that? So that's, I think, where I could see a lot of that outputs from an e-DiVA platform perspective. I want to just flip this off into where from here. And the thing that I was hearing, and it's not a technology problem, but it's more, how do we continuously keep capturing knowledge? And that goes back into those mechanisms. Because when I was hearing, one is personalization, right? How do I best give the curated content to someone with the right level of expertise that they can understand that? So it's not one fit all. And that's why I think the digital technology is all going towards. There was first one fits all. And let's not please compare this to ChatGPT and others, guys, because please understand the whole idea of the AI ChatGPT is we were all very generous in contributing data via Google for the last 20 years. So they had the power to generate that. Cannot, I think someone mentioned about Ask ChatGPT and you didn't get the answer because that kind of data does not exist. Privacy, and in a lot of the computer science world, we now use what is called responsible, not that we weren't, but we tend to do more of that. That's inclusive design, right? And what does that even translate into? Having the right people, inclusive information in terms of what is being presented to the right audience. I think that is being responsible. So how do we build these systems to be responsible is a very key aspect. But the key part is how do you take this feedback continuously? So I think the co-design is a continuous process. It doesn't stop. When it's deployed, it's handed over. It doesn't stop. And in some instance, the tech commercial world, these guys have actually mastered that. And that's why we go back buying these expensive phones, because the user interface design process that they have used, which is the co-design process where all the user design work came from, they have somehow figured out in the commercial space how well to do that. In the health space, I don't have an answer yet, but how best to actually translate some of those practices, because end of the day, even care providers, we have to fight with Epic, right? Or, all these systems which will not talk to someone else. It's not that APIs don't exist. They just have commercial boundaries and so many other challenges, and they just don't want to talk. So just in conclusion, I think co-design, what you mentioned, that is very critical, but I think where it needs to go is more towards that personalization aspect of how e-DiVA can become into a more personalized, carer-friendly sort of support system. Thank you.
Thank you very much, Prem, for your insights. And, actually, the people I really want to thank is the executive committees of the e-DiVA projects who criticized the first 76 videos that we produced. And the person I hate the most is Penny. She is the executive committee member, and she just says, no way, you have to throw it all away and redo it. And, I hate you a lot, but now I really thankful for all the advice and contributions. And but it's really helpful and it's a good lesson for us. And thank you very much. That is the reason why we have the beautiful video clips and the contents now. And now I would like to pass over to our co-chair, Bianca, to continue to list the rest of the discussion. Over to you.
So I have a question here for Kale and DY. You're not off the hook yet. What evidence do you think matters most to policymakers when they're investing in digital tools?
I'm not so loud that I can make my voice project to multiple locations. So microphone it is. It's a great question. Thanks, Bianca. Policymakers are increasingly talking about impact of the things that they fund, whether that be research or policies and programs. So there is a sense that we're moving a little bit beyond, the kind of outputs of things. So, how many people have accessed e-DiVA? How many people have looked at the website? How many people have looked at particular modules? Those sorts of things are important, but I think it's taking it a step further than that and thinking about the longer term impacts. So if we look at the modules that people are accessing on e-DiVA, for example, what trends are they giving us insight into when it comes to caring responsibilities? when it comes to caring issues and challenges that are particularly pressing? Is it predominantly about supporting people through changes in their behaviour or mood? Is it predominantly about supporting changes in the physical environment and the challenges that can be caused if the environment is not dementia friendly or inclusive? So I think starting to look at some of those broader trends and thinking about how that can be built into policy change is really important, because fundamentally policy change is really hard and really slow from a government point of view. But where there is compelling evidence to show that something is lacking in the current system and we need to implement things in a more systematic way, that is where we start to see some policy and program change, and that is where we can see trends of government investing in something. But I do think with something like e-DiVA, it is also really important to think about whether this is something, whether the data trends that we see, or whether we, you know, the sorts of engagement that we see from carers, is that something that we want to see implemented right across all carers in every country? So are they sort of fundamental changes, or are they changes that need to be tailored to a particular community or a particular, you know, is there particular languages that we should be looking at adding to e-DiVA or other tools and services? Because I think, you know, you always do need to think about what is a systemic change. What do we need to see with every single person so that there is that lift in access and quality of supports for all carers? And what do we need to target to particular communities that especially need those changes? So I think it's kind of a two-tiered way of thinking about research translation and translation into policy. But it's really important to think about that, because governments have an appetite generally to think about pilots and to think about targeted communities. It takes a lot longer to do systemic change, but if there are interventions and solutions that can help government to reduce the cost of caring responsibilities more, you know, at a more national or global level, then that's the kind of spur that they need. So I think it's kind of thinking about that across, you know, different levels of policy and program change and how you want to target those sorts of things.
I think you said it all. But the keyword on the evidence is cost. Definitely cost. How create impact? The fundamental changes. All these things matters to picking up the national system, national policies. How does this gonna make me achieve my KPIs, you know, from the policy perspective? These are the evidence, but the keyword is cost and impact and numbers. And if this platform program could benefit, the numbers of people going to hospitals will be decreased, and they will be embraced by the community who have connection with the system and all that. These are the evidence that they're looking for. Thank you.
Thank you, DY. We are open for Q&A. So is anybody in the room who's got a question they'd like to ask, please do put your hand up and we will bring the mic over to you. In addition to that, while you're thinking about your question, I might just read one out perhaps that's come through online. I might target the question, if it's all right, to you, Simona, and to you, Jane, which is, this question's from Selena, and she asks, testimonies are important. How can it encourage those to know that they are not alone?
I think, yeah, maybe some day-to-day examples, maybe to capture some of those. I know you already do in the videos, but a little bit more of just you know, what to expect, what reactions to expect, and so that they feel that it's familiar, that they're not alone, that other people are experiencing these certain emotions, feelings, thoughts when it comes to caring for a loved one. Jane?
Yeah, the one element that is missing from telling their own stories. So it might be, I mean, stories are really hard. That's what people relate to, and if you can hear somebody else talking about the fact that they felt exactly the same way as you did. It's not so much describing what you're going through, but how it made you feel. And a lot of carers actually don't reveal how hard it is because they feel they should be doing a good job. Don't want to admit, but perhaps they're really struggling. So I think some real life stories would be very powerful as an adjunct to what you've already got there.
Thanks for that, Jane. I think that's really important. Importance of being validated, heard, seen, and not to be cast or framed as a superhero. We've got a question in the audience from Penny. There's a mic coming over to you.
Thanks. Is that on? Yes. I'd just like to go back to the health economic point. Given we've got all these experts in the room, I think that is the nub of actually getting stuff into policy, and also looking at sustainability for any of the digital platforms. And I guess that I'm interested, I mean, things are rattling around in my head about how you do a health economic analysis, but it strikes me that the longer that people can stay at home is better for the individual involved. That's what also the family wants. And no, I'm getting a shake. No, not necessarily. Some might want them at home. Some might want them quickly in care. Yeah. The government wants them at home. Okay, I'll stop talking now. And
Look, I mean, I think the big problem is that it gets really, really difficult when you're at home caring for someone with dementia. If it gets to the stage where you really can't manage on your own anymore at home, the big dilemma is, where does the person go to? I mean, there's enormous guilt around what people used to say is, you know, I had to put my husband into residential care. And I always say, no, you didn't have to put your husband there. It just became too difficult for you to be able to look after your husband on your own at home. But the problem is residential aged care is not always ideal setting, and things are moving forward somewhat, but the models of care and the types of arrangements we have for people with dementia in residential care are far from ideal. So people are really reluctant to move into care. So it's really difficult. Yeah.
Can I say it's not an easy decision to put somebody into care. In fact, it is really, really, really difficult. But there can be lots of circumstances, whether it's just looking at home, it could be, you know, there could be some major financial difficulties, like if a husband has, you know, has had foul businesses and you've got financials to deal with and all sorts of things. So it doesn't say you can't even live in your own home anymore. So, you know, it's not just even just the caring aspect, but it could be other factors as well that, you know, can lead to somebody needing to be in a residential care situation.
I was just going to finish off the residential versus home argument. So having only worked in ethnic specific services for 20 years, carers are waiting for me to say, you need to put mum in a nursing home, because then they can blame me. It was the service provider, not me. There is twofold, the number of NCAT applications that we have to do because kids are trying to keep the house and the client's actually not dignified at home. That's one element of it. So we do force people into residential aged care as service providers, one of which I'm thinking this app can help. I'll say, well, I'll hold off a month if you complete some of the modules in the e-DiVA app and demonstrate to me that you're putting things in place. So thank you. That's that question that you're probably going to ask me. And secondly is they're waiting for somebody else, the doctor, the geriatrician, to say it's time now to make that, to take the guilt. It's a guilt decision that keeps people at home.
Just circling back to the health economics component of what we've been talking about, I think, you know, the stories that we've heard about people's personal experiences highlight something pretty powerfully, which is that there are tips and tools that can make a difference if you don't know why a behavior might have changed, why something, you know, might be experienced differently, such as the rug, those sorts of things. And they can make a difference, but they don't always make a difference. So I think that the value of things like this is that it potentially, not necessarily, but it may potentially delay people needing to seek higher levels of care or residential care because there are ways of modifying the environment, engagement with people, the way that you access services, etc., that can make a difference. But ultimately, we can't get around the fact that dementia is a degenerative disease and that it is not curable and it's fatal. So care needs will continue to escalate. And I think that it's important for e-DiVA, particularly in thinking about it going forward, how it is positioned in providing support to carers who haven't received it in the way that they need to for a certain period of time. But what happens when those care needs escalate? What happens when carers are no longer able to support somebody safely at home, either for their own safety or for the safety of the person they're caring for? So I think those kind of clear trigger points are really important. And that makes it easier to think about the economic benefits, you know, if we want to put it into kind of numbers and dollars, because we've got a clearer sense of how people are moving through the system and the timing of people moving through the system. That, by the way, is not easy to measure from a, you know, from a data point of view or from a cost point of view. There's a lot of theory and kind of assumptions that have to sit behind that, but at least gives us some, you know, kind of framework to work around.
First of all, I really found that discussion very interesting, remembering my own journey where I had kept my mother at home for a couple of years and found that, you know, one of my brothers who was basically saying, no, we can't have mum in care, but he couldn't have her at all at his place on the weekend or anything, so I had no break. So I just asked him to look after her for 2 hours a week for a few weeks. And he said to me, we can't keep her like that. 2 hours a week. So I think it can be, but that I think is not, I think that's a normal part of the process that people go through. And I think it's useful to cover that kind of area. But even more interesting for me is something that I think a couple of the people said is about that a computer will never replace a human being. And the need for people to be able to link with someone, because who do you link with when you are going through hell and high water trying to just survive as a carer, as a worker, as a mother, as a, you know, you really haven't got time to worry about going out and finding digital stuff. You're there just doing, you know, you're just getting there. But I do think that if there are ways by which the digital material can go to the person by holding events which are held by people like many of the people in the room, and I'm in a similar role, where you are the one who brings people together. They come to you because they trust you, they care for you, and they they know that you will understand what they're on about. And then you can really not only provide the tool, but also provide the environment in which those people do not feel alone, that they're able to link with each other. Because I think the tool on its own, without that other element, it becomes something that's lovely to have, but is hard to achieve for carers. Yeah.
We're actually out of time. I'm sorry. I'm very sorry. We have to close the discussion. Sorry, Libby. I'm sorry.
Can I just say, I just wanted to say that Libby Rufford, for those of you who don't know me, interested observer. But the result I think that was just stunning was the fact that I had a better relationship with the person living at home. And all this talk of economic evaluation, the thing that makes the difference is love. And here you're showing that this thing helps us love the person we're living with who's really challenging, or get on a bit better with them when they're really challenging. That's the thing that you could really bring out, because this is the very exciting thing about your project. And you have this opportunity to change the paradigm about what do we value as a society, and maybe just improving the capacity to love the ones we love, or to be with the ones we love, is the outcome, is the impact.
Well, I'm glad we gave you that opportunity, Libby, because you kind of summed it all up. Very grateful for that. I'm going to close our panel discussion because we are over time, and I know there's other commitments to do. I won't say too much except to thank their very valuable input, us discussion, and for concluding with the message of focusing on love and the aspects, finding a positive aspects in a changed relationship. Thanks.
And I probably could have said a few words about that as the health economist in the room, but I won't, because those questions are ultimately of value, and how much value do we place on relationships of quality of life, and sometimes economics isn't the answer to that. And so I'd like to welcome Henry up to the stage to just give a few closing words for today.
Well, I think we could have gone on for a lot longer. There's quite a lot of passion in the room about this. And, very hard to convince a government that you've improved love, so you should fund these services. So we need to have both, obviously. e-DiVA is a tool. It's not going to be for everybody. It's not going to be for everybody at every stage. And some of these solutions may seem don't work. And we don't talk much about when things don't work, because we want to show good outcomes. But in reality, often things don't work as well, and then we have to find other strategies and other people. Today's been quite varied. It's only half a day, but it feels like 2 days to me, because there's been so much information that's been sent. Tracy, I'd like to thank you for sharing today. You've done a great job. I'd also, the organizers for this, Tuan, and the people behind Tuan, Zara here, and Upasana, where are you now? Over here, okay. On this. And of course, all our speakers. Katrine, who got out of her sick bed to do this online. I had some special connections with Katrine, as she mentioned in her thing. And so I'm really grateful that she was able to do that. Kale, you've taken a couple of days out of your very hectic schedule to come and join us. So we thank you for that. And for all the other speakers, Upasana, Tuan, the panel, and DY, who's come from Indonesia, and is such a passionate advocate for people with dementia and for their families, and for Alzheimer's Disease International. And Jane and Simone, with lived experience of being a carer, and Janet, who joined us today, her husband had young onset dementia as well. So I know all about that. And Anita, I had not met you before, but it's really refreshing to hear about what you've been doing. So, I mean, we know the numbers. We don't have to go through all that again. We know about how complicated the system is. And we know that there are challenges, and minority groups face special challenges. So it's not just people in Vietnam, it's Vietnamese people in Australia. It's not just Indonesians in Indonesia, it's, where are you? Indonesians in Australia. And of course, Chinese in Australia, and Arabs in Australia, Italians and Greeks, and all of those. And people live in rural areas, and people who don't have any families. There are so many things, and of course, it keeps us all very busy in trying to work out solutions for them. But we're now at this crunch stage of the challenges of how to make this happen, and that's what tomorrow will bring.